dentistry. Okay, so okay, so general dentistry is something which is my interest, and I used to do most of the dental procedure stuffs, and I am into endodontics. I am into implant dentistry. I am into restorative dentistry, and I have been practicing implants since 2016. Now it's going to be more than 6 years I have been practicing implants. So it's like, when you are into general dentistry, it becomes quite important that you have an idea, and you have an approach where you can actually perform the procedures, performs the maximum number of procedures into your clinic. And as because I am into a remote area where there is no presence of any postgraduate here, so it becomes quite difficult for me to perform complex cases, and that's the reason, that was the drive for me to learn things and execute into my clinical practice. So whosoever means right now, the budding dentists who are actually coming out, and who have started their recent practice, so I would suggest them that they should keep a pace with the advanced technologies, and means day-to-day updates of the various parts of dentistry, various aspects of dentistry, and they should accommodate the maximum number of procedures into their practice so that they can succeed. And in this competitive world, it is important that you have a knowledge of everything, okay, a brief knowledge at least, so that you can suggest the person means the correct thing, and suggest, or even if you are actually means you are knowing something, some small amount of thing about the particular procedure, you can, and if you are not able to perform that procedure well, then you can refer him or her to the correct place. So no, not wasting so much of time, we will start our presentation here. And I would like to tell you all one thing, that post endodontic restorations is a huge topic. And means if I try to cover each and every aspect of it, it will take me days to cover it. Okay, so I will be very brief. Okay, and I will tell what all things are into my practice, and what all things I practice in my clinic, and what I have learned from my mentors. I will be very brief about that, and also I will try to keep it short and sweet. Okay, I guess everybody is ready. So let's proceed. So it is important that we plan our treatment. What if we don't plan our treatment? It is a very famous quote that if we fail to plan any case, you are actually planning to fail. Okay. So when a patient comes to your clinic, you see a particular case, okay, and you decide at the moment that we will perform a root canal treatment over that case. And we fail at the same point to plan the restorative aspect of the particular case. What will happen? The patient will undergo the root canal treatment, and then what? You will ask the patient in the mid of the treatment that, oh, doctor, sir, we need to perform a post and core over this case. The patient will say that I came for a root canal treatment. Now he is saying post and core. And also, sir, we need to perform a crown over it. Okay, then he will be confused and he will feel cheated. So it is important that you make it very clear your treatment plan to the patient. You present that treatment plan to the patient from the start to the finish, so that you have a smooth flow of um, treatment, as well as the patient is also, he has accepted the treatment plan and is ready to pay you for the particular treatment plan. The reason I am saying this, you cannot go haphazard and you cannot plan your treatment in the midway. You cannot plan your post and core after performing root canal treatment. Okay, so you need to be very clear that where we have to plan a post and core, and where we have to plan an onlay, where we have to plan a core, only core, where we have to plan everything, So it is very important to plan your treatment from the starting to the finish. Now, some points that I would like to tell you all about the RC treated tooth versus the healthy vital tooth. We know that whenever we are performing RC, a root canal treatment, we have to compromise the tooth structure further. Why? The caries was present there, we have to remove that caries. After removing the caries, we have to perform the excess opening as well. Then what we are actually doing? We are actually compromising the tooth structure further. Yeah, definitely we can go for minimally invasive dentistry. Okay, and we can means nowadays there are various kinds of the excess openings where we can actually conserve tooth structure, even though we are invading the tooth. So when we are removing the caries and going further inside the tooth by the excess opening, we are actually losing the tooth structure, right? So we have to understand that RC treated tooth has got loss of tooth structure as well. And also there is compromise of the moisture content of the tooth. It is not as same as the vital tooth. The moisture content of a non-vital tooth is different and a healthy tooth is different. Why? As because you are performing the pulpectomy. You are actually removing the pulp from the canals, right? When you are removing the pulp inside from the canal, the pulp is something which keeps the tooth vital and provides the moisture as well. And here, when we remove the pulp, the moisture content of the tooth gets compromised, right? And also, an RC treated tooth has no pulp. Also, the RC treated tooth is compromised strength wise, and the nature of the dentine toughness is also gone down. Also, you need to understand that when we are actually performing root canal treatment, we are using files, okay, and we are further increasing the size of root canal and making it a in a conical shape. Then further we are compromising with the pericoronal dentine and the root dentine. In that way, we are compromising with the tooth structure, right? The strength of the tooth structure. Also, we need to understand that whenever there is caries, there is compromise of aesthetics as well, right? So these all are the salient features of an RC treated tooth versus a healthy vital tooth. Now, we have to understand the compositional changes in non-vital teeth and also the influence of the endodontic therapy. Now, what all changes does take place? There is a slight change in the tooth moisture content of around 9%. Also, it is associated with the values of young modulus. When the modulus of elasticity changes, it reflects over the tooth as well. Means when the young modulus increases, then the flexibility or the um, modulus of elasticity, the elasticity of the tooth is gone down, and when young modulus is has gone down, the elasticity increases. So also it was found that there was no decrease in compressive and the tensile strength values. This is a very important point. Between a vital tooth and endodontically therapeutic performed tooth, there is no difference between compressive and tensile strength values. Also, it was found that there was no difference in collagen cross linkage. That means there is a slight change in the strength. Also, you must know that the chelators that we are using, chelator means in the form of EDTA, right? Or in the form of any acid. If we are using, we are actually it actually leads to dentine erosion and surface softening. Also, when we use hypochlorite, it has some kind of proteolytic action by the hydrolysis of the long peptide chains, such as collagen, and we are actually removing the collagen fibers from dentine as well. And these alterations can actually impact the dentine and the root structure, and also alter the bonding properties of the substrate. It is very important to note down that it alters the bonding properties of the substrate. So always remember, the bonding properties of a RC treated tooth is never the same as a vital tooth. Okay. Also, non-vital teeth in the older patients, have got a higher risk of fracture. The reason behind that is due to the, aging, the secondary and the tertiary dentine is basically the form. They have lost the capability of forming secondary and tertiary dentine, and due to that, it is again a compromise in the structure. The chemicals that we are using in the canal irrigation and disinfections, as already mentioned, interact with the mineral and organic contents and then reduce the dentine elasticity and the flexural strength of the tooth. Okay. So now, okay. Okay. So when there is loss of tooth structure, okay, due to various reasons, like due to the conservative excess cavity, then how much is the compromise with the tooth stiffness? It is around 5%. If it is instrumented and obturated, there is a very slight reduction in the resistance to fracture. This flow chart shows you all these things. And also, when the excess preparation is done, where we are actually involving one of the marginal ridges, and you very well know that the strongest part of a tooth is the marginal ridge. And if we are compromising and including those marginal ridges in our excess preparation, then there is a huge reduction in the resistance to fracture, that is around 20 to 30%. And studies have shown, if we go for MOD preparation, that is mesial occlusal distal preparation, in the excess form, the reduction in the resistance form is around 60%. So you can see that how much compromise we are doing just by going and involving one or two marginal ridges. So it is important that we conserve the tooth structure. Okay, if the marginal ridge has been compromised and the marginal ridge, the caries has involved the marginal ridge, at that point of time, we cannot do anything. We have to include those marginal ridges while we are preparing the access. And we should know that how much reduction in the resistance to fracture takes place. Okay, so these are the data. So basically, we need to understand what protects the tooth from fracture. The tooth from fracture is protected by the presence of the residual hard tissue in the cervical area. The cervical area of the tooth is the weakest part of the tooth. So it is important that we conserve the maximum amount of the tooth structure in the cervical area, right? So what it actually is known as, it is actually known as the ferrule. So it is important that we have ferrule in order to increase the strength of tooth. So what is the ferrule effect? Ferrule is a term that is referred to a circular band of tooth structures left after crown preparation in order to support and stabilize the overlying dental crown. Okay. So diagrammatically, I will show you what is actually the ferrule. Here it is the, sorry. You can see the remaining tooth structure above the margin. Wherever you have placed the margin, the remaining tooth structure above that margin and circumferentially, that is 360-degree, it is known as ferrule. So it is important that we have a remaining ferrule and the ferrule effect so that it resists the fractural forces, the compressive forces, the lateral forces, every kind of forces this ferrule actually resists. So it is important to have this ferrule. And how much of ferrule is needed? We will see it in the further slides. So some points that should know about ferrule and ferrule effect is that it should be minimum of 2 to 3 mm, and it should be sound tooth structure. It should not be compromised or carious tooth structure. Cannot include caries in ferrule. Okay, so you, after removing the caries, the remaining tooth structure above the margin should be at least 2 to 3 mm. Also, a properly executed ferrule significantly reduces the incidence of fracture. I told you this earlier. Now, this reinforcing at the external surface and dissipating forces that concentrate at the narrowest circumference, that is cervical area of the tooth. So what it actually does is it dissipates the forces that is basically concentrated at the cervical area of the tooth. That is the weakest part of the tooth. So it basically dissipates those forces and it reinforces the tooth in that way and resists the fracture. It also resists the lateral forces over the crown and increases the resistance and the retention of the restoration. Retention and retention and resistance of the restoration. That means the core that you have actually placed over it. Okay. So it actually resists the lateral forces as well. So what if ferrule is not present? If it is not present, it is better to extract that tooth. And if it is present, if it is not present, you can also try to achieve it. Achieve it by the help of crown lengthening procedure. It is one of the ways by which we can actually achieve ferrule effect or ferrule. Another way is to perform an orthodontic extrusion of the root stump, and this is the way we actually perform the extrusion. Now yet again, you need to understand that when you are performing orthodontic extrusion, there is something called root is to crown ratio. Okay, so it should not be compromised. Okay, the root should always be longer at the end after the extrusion or after the CLP, that is crown lengthening procedure, then the crown. If it is getting compromised, then you need not do perform such things. You should extract that tooth. Okay. Also, you can do one thing more, that is extraction and intentional reimplantation, positioning the tooth more apically. Means you extracted it and you placed bit apical 2 to 3 above that, and you splinted it for few days, for around 10 days. Okay, and then remove the splint. Okay, in that way also we can achieve ferrule. Okay, so if the ferrule is compromised, that means if you have ferrule but it is not equal circumferentially, means one side, in the mesial side it is 2 mm and in the distal side it is 1 mm. In that case, it is always recommended that you go for cast, post and core, and not for fiber, post and core. Okay. Now, what are the treatment goals? The treatment goals are endodontic restoration. You know that it is regaining the aesthetics as well as the functions to achieve the optimum oral health. Also, the restoration, the post endo restoration should protect the remaining tooth from the fracture. It should prevent the reinfection of the root canal system, as because it should have got good coronal seal, right? And the replacement of the missing tooth structure, whatever tooth you have lost, it should be replaced by the help of those restorative materials. So these are the treatment goals of post endo restorations. Now, this is a very beautiful flow chart that I have prepared. I guess it will make your work easy. What I have divided it into two parts, that is structural loss is less than 50%, which I will deal in the next slide, and when the structural loss is more than 50%. Okay, so when there is structural loss more than 50%, there can be two conditions: sufficient amount of ferrule, and another condition is ferrule compromised. So when you have sufficient ferrule, any kind of post and core will work. Either you go for a cast fiber post, or cast post and core, cast metal post and core, or you go for adhesive post, that is fiber posts. Any kind of post and core will work. And over it, it is important that you provide a full coverage crown, as well as or you can go for onlay or overlay over it. When the ferrule is compromised, that I have told you earlier, that one side it is 1 mm and one side it is 2 mm. In those cases, I will recommend to go for cast, post and core only. And over it, a full coverage crown should be placed, not any overlay or onlay. Okay. Now, when the structural loss is less than 50%, what all restorative materials we have in two options? First is the crown. You can go for PFM, all ceramic or zirconia crown. Either you can go for direct composite restorations. In direct composite restorations, we can go for inlays, onlays, overlays, and ceramic, all ceramic restorations as well. You can go for onlays, overlays, and endo crowns. So we will deal, and I will give you, I will show you certain cases where I have, performed ceramic overlay, endo crowns, and direct composite restorations. Crown is something which is, means everybody knows. So we will discuss less of crowns and more of adhesive dentistry, that is direct composite restorations, and about ceramic restorations. Okay. Though one of the crowns, that is vertical preparation, I have covered in this presentation. I will show you that in the last. Now, direct composite restorations, what are the indications of those direct composite restorations? See, every material comes with indications and contraindications. Every condition comes with indications and contraindications. restorations. So it is always you should always know means which thing we should perform where. So when there is root canal treated case where there is class 1 cavity, and uh, circumferentially all the walls complete, your every wall is more than 3 mm in thickness, just go with direct composite restorations. Okay, you need not provide any kind of cuspal coverage in those cases. It will work. Okay, when the root canal treatment is done in a class 2, class 3 cavities, and Ellis class 3 fractured tooth, sufficient amount of residual tissue is present and it is intact, and also if the neighboring teeth are healthy, and if you are performing it in the young patients, then you can definitely go for direct composite restorations. Also, it is important that in certain cases, in such cases, there is no severe para functions. There is no group guidance. Okay. If there is severe para functions and it is occluso functionally compromised, then you are going to, means end up into a difficult situation. So you need to check the occlusion as well. So that's the reason I told you planning is something which is very important. If you actually exclude occlusofunctional condition and you plan your treatment, you will end up doing blunders. So please avoid and please plan your treatment before execution. It's very important. So let's proceed with the cases. Okay. So first case that I would like to present you in front of you is of direct composite restoration. Here is the clinical picture of it. The first picture is basically it's showing a proximal caries. This was a young lady around 23 years old, and this was the case which I performed during the COVID period. So COVID period was a very difficult period, right? Especially for the dentists. At that point of time, we were in dilemma that should we send the means should we actually uh, receive crowns from the lab or not? That's because we were in dilemma that as if we can get or caught up with the COVID virus, right? So we used to avoid sending cases to our labs. And this is something which I want to present you here, that actually what happened in this case, and in the mid of the COVID, I actually avoided sending cases to the labs. Before that, in 2018, I learned the concept of injection molding, and I learned the concept of BioClear, and that helped me a lot. As because the indirect restoration, the direct composite restoration that we perform through injection molding technique is something very near to the monolithic restoration. Okay, so that is the concept behind that. Okay, we use bulk fill composites for the restorations, and it works wonderfully. It works wonder. I have so many cases with follow-ups, and uh, it's going to be, I guess, since 2018 I have been performing such cases, and I have around 4 to 5 years of follow-ups in my library. So that's the reason I am presenting this case in front of you all, that one option is this as well. You can perform such cases, but there are indications of doing such cases as well. So what you can see here is I have actually performed a very conservative access opening. Okay, and you can see that most of the tooth structure is preserved. you can see most of the cusps are preserved. Okay, the only compromised cusp is the distolingual cusp. Okay, so the reason I decided to go with injection molding technique and bioclear restoration over this case. Okay, the first picture is of access opening. The second picture is of confit X-ray, and the third picture you can see here, it is post obturation picture. Okay, so this is in the first picture you can see the bioclear assembly that I have applied. Everything, you can see clearly see the wedge, the yellow color wedge, as well as the bioclear matrices with a dual force ring. Okay, this is the purple ring which I have used here. And then in the second picture you can see I have injection over molded. Okay, so it is claimed that this injection over molded restoration has got wear resistance equal to the ceramics. Okay, that is one of the reasons that I perform these injection molding monolithic restoration in certain cases. So this was the final clinical picture after finish and polish. You can see very well finished and polished and contoured. Marginal ridge is also, means I tried to rebuild the marginal ridge. And final radiograph is visible and in front of you all. There is a concept of, preserving the soffit. I'm not going deep into it, but the pulp horn that you can see nasally, that is something which is known as soffit, and we need to preserve those soffit. And there is a science behind that and scientific reason behind that why do we need to preserve those soffits. But I am not going deep into it. Okay, so this is one of the cases, and you can perform injection molded restorations over such cases. Okay, now this is another case of premolars. Believe me, I have stopped placing crowns over premolars, as because these premolars are highly, fragile tooth, and they are means they have to bear load as well, the compressive as well as the flexural forces. And these lateral forces are very dangerous for these premolars. Over it, when we are performing root canal treatment, it compromises the ferrule drastically. So it becomes, very. I have stopped doing crowns as because I have seen failures, and I don't believe placing crowns over premolars. I usually perform direct or indirect restoration, that is ceramic restoration, like overlays or inlays, which is very conservative in nature and preserve maximum amount of the tooth structure in premolars. In case if the patient is means continuously asking me and means he wants to convince me for a crown, I actually refer those cases to my friends, or else I just go for direct composite restorations in those cases and ask them to wait and watch. I guess I haven't seen any failure till date in which I have performed a root canal treatment in premolar and direct composite restoration. I haven't seen any failure till date. And I have been performing direct restoration since 2018, 2017. And it's going to be more than 5 years now. So this was the first picture that you see here is the isolation. And after isolation, I have put up the assembly, the bioclear assembly here. And you can see how nicely it adapts to the tooth. Okay. And the ring that I have used here is the orange ring, and this is something which is from Dentex India. This is not from BioClear. This is a different ring. Dual force, though it is a dual force ring, twin ring, that is having, you know, these rings have got, you know, enough, it provides good enough forces, enough separating forces, and these rings are something which is which works wonders. So you should have these rings in your you know, in your clinic. So this is the we have in the first picture I have actually performed the injection molding, and I have injection over molded, and then the final picture is of after the finishing and polishing, and you can see how beautiful flush you know, restoration it creates, and also you can see proper wide and beautiful contact. Now, direct composite restoration case number 3. It is important for you to have a vernier caliper in your clinic, as because this will tell you how much of width and of the remaining tooth structure is present. So you can see here, here the basically the mesiobuccal, I guess, mesiobuccal cusp or mid-buccal cusp was compromised, and rest all the cusps were okay and more than 2.5 mm. So that's the reason I decided to go for direct composite restoration in this case, and not any cuspal coverage in any form. Okay. So what I did basically here, that the compromised cusp was actually reduced, and it was reduced till I achieved the width of that particular cusp, the width of that cusp till 2.5 mm. Okay, so I reduced it till there. So you can see in this picture that I have reduced the cusp, that particular cusp, the compromised cusp. And also before that, what I did was I created an index. And how did I create that index? I applied a little bit of Vaseline over the tooth and then used the flowable rubber dam. The flowable rubber dam to create an index, and that index was again used to build my the lost cusp or the compromised cusp that I reduced. Okay, so in the second picture you can see how beautifully the cusp was rebuilt. Okay, and in there is little bit of composite, flowable composite was used, and then it was layered, and at the end I achieved this result, and this was, in this way the case was concluded. So this was also a very young, you know, around 19 or 20 years old patient, male patient, and I performed this thing over such young patients. Okay. Now, a young champ again came into the clinic with you know, lot of pain, acute pain, and he was around 16 years old. He is around 16 years old. And here we had enough amount of tooth structure, more than half of the crown. So we decided to go for direct restoration. Also, this case was considered for an orthodontic treatment. That was also another reason where we end up, you know, doing direct composite restoration for this case. So it is important that we plan these cases, right? So it is important that you get a mock-up of, you know, future restoration, so that you can actually make a putty index of it and use it to create a palatal shelf. How? You can see here in the second picture, you can see there is a wax mock-up, okay, that I got it from the lab. And then I made a putty index with the help of lab putty, and then I placed it over the tooth. And this is the first picture shows you the palatal shell. Okay, And then I used the normal contoured matrices to create the marginal ridges, the distal and the medial marginal ridges. Okay. And then the complete restoration was done through, in the form of layering technique. And you can see the final restoration. This was the final outcome of the case. It is important. Now, the thing is, my wife has to perform an orthodontic treatment over this case. So it is bit easier when you are, when you place composites over such cases. And also, even if I actually, means if we didn't perform any kind of orthodontic treatment, this would have gone and run along for a long period of time. So this was the final radiograph. I have performed the root canal treatment in the single visit, and also the restoration was performed in the same visit. Another case here, this is an interesting case. This was a case where the patient was, not able to afford my ceramic onlays or overlays. Now, why did I plan ceramic onlay in this case? You might have means you might say that you could have gone for a crown over this case. But as you can see in the distal side, it was like I could not place my margins in the distal of this 7. So the reason that I planned an overlay over it, but patient rejected my plan as because he was not able to pay me that much of amount. So I decided to go for an indirect direct, you can say, or first of all you get a mock-up done. Okay, now this mock-up is something which is going to help me my lingual wall. So I will make a putty index of lingual wall, a putty index of a lingual wall, and then place it over the patient's mouth, and will achieve the wall as I showed you earlier in the earlier case. And you can actually perform a direct composite, good, beautiful direct composite restoration over such cases. So this was the case. You can see distally it was very difficult to place margins. So you need to plan, means you cannot blindly say that no, we will go for crown over this case. And when you actually start drilling and you see that there is a high tissue attachment there distally, and you say, oh my God, distally it will get compromised, so we will perform an overlay here. So it is not at all, means acceptable to the patients. So you need to plan everything. So always check every aspect of the tooth. So distally here, the attachment of the gingiva was very high. And that was the reason that I couldn't place my margins deep there. If I could have, if I would have gone for a crown, the margin would have, means I would have to place a supragingival margin, and the crown height would have been, 2 mm, around 2 mm of the crown height distally. But in the macro retention form, we need to have at least of 4 mm of occlusal height to achieve retention as well as resistance form. Definitely, when we are going for indirect restorations or indirect adhesive restorations, in those adhesive restorations, you depend over the micromechanical retention and not macromechanical retention. When we talk about micromechanical retention, that means you need to increase the surface area of your enamel, dentine, and then you apply a bonding agent, and that bonding agent is going deep into the those micro pores, and it is actually creating resin tags, and it is holding your restoration which you have placed above. So in micro retention, you don't want a 4 mm of, just like the macro retention form, that no, 4 mm of crown height is important. The 4 mm of preparation and 5 mm of preparation is important. No, it is not such that, it is not like that in micro retention, right? So it is like what I did was I don't have a picture over there because the patient was quite skeptical about that and was not allowing me to take picture while it was quite difficult for me to take picture while placing and putty index and taking a picture. So I avoided that. So here what happened, I actually placed a lingual putty index and created my lingual wall or the missing wall. And once I created that missing wall, apply a circumferential matrices, that is Toffel-Mayer over the tooth, and then you can actually place your direct composite and you can layer it and you can achieve a very beautiful restoration just like this, as you can see in the last picture. Okay, this is one of the ways. Now I told you earlier that when we go for when there is something, sometimes you get such cases where the tooth is aesthetically compromised. And this tooth is aesthetically compromised as because this faced trauma years back. And due to that, what happens, you very well know that hemorrhage takes place and the blood goes inside the dentinal tubules, and those dentinal tubules, the blood has got heavy metals, and by a period of time, those heavy metals reacts with various kinds of various kinds of chemicals and all, which we eat on a daily basis, and then they form heavy metal, heavy molecules, and that leads to discoloration of the tooth. So what all things you can actually do in such cases? Either you can go for a internal bleaching, okay, or if you can mask this discoloration with the help of veneer, then I will suggest you to go for lithium disilicate reinforced glass ceramic veneers. So in this case, this is the preparation of veneer. This is something which is window preparation that I have performed here, and I took the impression and sent it to the lab. And this is the final restoration, final veneer restoration. So you can see the color has been masked with the help of this veneer. Now this is the case of indirect restoration, okay, where we actually performed post and core as well. So this young lady came to my clinic with fractured old crowns, okay, and she was highly depressed and highly disheartened by the old dentist who performed such crowns over those teeth. And you can see that how much compromise of the tooth structure has taken place after the fracture. So this was the second picture, shows you the initial condition. Okay, so it was like poor root canal treatment as well. So I actually planned retreatment of those root canals, and after retreatment I planned post and core. And now why post and core? As because I had enough amount of ferrule, that was around 2 mm, and that's the reason I decided to go for post and core and not replacement of the tooth with implants. Let's give last chance to these teeth. I asked the patient, and we we consensually we actually decided and to go for post and core and crown over the root canal treated tooth. And we started with this, and I actually checked the three-dimensional ferrule. You can see here the three-dimensional ferrule is enough, and also the pocket depth you should check. So this was done with the help of a probe. Now this was these teeth were isolated, And after isolation, root canal treatment was performed, and immediately after root canal treatment, um, post and core and the final tooth preparation was done. Now, this is the way I do the shade selection. I actually take photographs of that and then I send it to the lab. And good, communication with the lab is important. And it is also important that you send such aesthetic cases to good labs, as because they will fabricate good and aesthetic crown, good and very beautiful crowns for you. So and they understand all those things, so that's the reason I will suggest you that you go for a good, uh, whether it is expensive doesn't matter, you should go for a good lab and good technician for such cases. And these were the crowns received, and then the biofilm was removed with the help of sandblaster, and total etch technique was performed, and after etching the teeth were bonded, and this was the final smile of the patient, and she was very happy at the end. So this means you can actually do wonders with uh, root canal treatment and restorations. Now indirect restoration, case number 3, where I performed endocrown. See, endocrown is something which can be performed where you have got good amount of enamel rim, okay, and also where the occlusion is something which is treated so much. In certain treated cases or high occlusion cases, deep occlusion cases, it is quite difficult to go for a crown, as because it requires macro retention, as I told you earlier. For macro retention, you should have a minimum of 4 mm of crown height above the margin that you are placing. Above the margin, that 4 mm is sometimes not possible to achieve, and in certain cases you can go for adhesive restorations where you have a good amount of or good enamel rim present, and in certain cases I perform endo crowns. So in this case, good amount of enamel was present and the occlusion was compromised. So I went for a micro retention adhesive crown over it, the endo crown, and you can see the preparation in the second picture. You can see the occlusion means this was the earlier means the picture taken after the performance of root canal treatment, not after the preparation. And in the second picture, you can see the isolation, proper isolated. And then you can also see the substrate for the bonding, proper enamel rim and dentine. And then this overlay was bonded. You can see the flush bonded restoration over the crown. Now this has been, means more than 2 years now, and patient is doing very well. So final restoration. Another case where the tooth was compromised so much. In that case also, I actually went for, as because this was also a very young boy, 18 or 19 years old boy. In certain cases, we need to, means preserve that. We should go for minimally invasive dentistry, and we should uh, choose our, restoration very wisely. So in this case, the lingual wall was highly compromised. So I decided to go for a margin elevation in this, and I used this Toffel-Mayer matrices band in order to raise my margin. And after raising the margin, you can see the preparation that I have done. This is something which is veneer lay preparation, something called veneer lay preparation. So a combination of means veneer type of preparation and overlay kind of preparation. So this was the substrate for bonding, and you can see good amount of enamel remaining. and you can see the frosted enamel over there, over the second picture. Okay, so that is something which is the enamel. And then what we actually do in such cases, we actually etch the intaglio surface of our overlays, and with the help of hydrofluoric acid, so hydrofluoric acid, and then we actually apply the silane. And after silanation, we actually some people say to apply bond, some people don't say, but I usually apply a thin layer of bond as well. And then with the help of flowable composites, viscous flowable composites, I bond my restorations. And this was the final outcome of the case, and you can see a very good fit, uh, overlay and proper margins merged into the tooth. A very beautiful restoration at the end. Now, one last case that I would like to show you all is the case of vertical preparation. Now, this is a very new concept, not a new concept, but it is an old concept which has been presented by, in a new way. So, I have learned this concept with one of my Portuguese mentor named George Cardoso. Dr. George Cardoso has taught me this, and this is something. In the first picture, you can see that the beautiful soft tissue structure is surrounding the crown. So what we actually do in vertical preparation, we prepare less horizontally and prepare more vertically. In that way, we actually, are more conservative. So here in this case, the tooth was highly compromised. I asked the patient to get it extracted and then get a, means implant over that tooth. But the thing is, the patient was not ready, as because he had to travel, and he was not going to come to my clinic for next 2 to 3 years. So he decided not to go for it, and we had a a mutual understanding. And after that, I told him that it can work, it cannot work. We can go for a vertical preparation and a crowning over this tooth. Then he was ready to go for it, and you can see in the first picture I have performed a post and core, fiber post and core, and then vertical preparation. For vertical preparation, I have got bad burrs, and those bad burrs are something which is non-cutting. It has got non-cutting end, and it does not tears or uh, traumatize the gingiva while you are preparing subgingivally. So here what we actually do is we actually place the restoration subgingivally, and we take the grip or the ferrule subgingivally. So in this cases, uh, in such compromised cases, you can actually go for vertical preparations as well. And then what we actually do is we take an impression and send it to the local lab, where he fabricates a very well contoured and very highly polished uh, temporary, and we place the temporary for a few weeks, and after that we take an impression again and send it to the lab. And the restoration, the choice of restoration is basically monolithic zirconia, as because monolithic zirconia is found to be highly biocompatible, and the glazed zirconia is um, it adheres less of plaque subgingivally, and that's the reason there is no inflammation around the restoration. So, and also you need to understand that the margin is decided by the lab. You don't decide the margin. So the margins are decided by the lab, and then they fabricate a crown over it, and those zirconia crowns are sent to you, and you lute the crown. And you can see at the last photographs that you can see is the luted crown, and you can also see the contoured, means beautiful gingiva and keratinized gingiva over the crown. It is healthy, and it was performed around 1.5 to 2 years back. Till date, the patient hasn't, means reported any, disaster right now. So I have experience of such crowns as well, and I have follow-ups of around 3 years of such vertical prepared cases. So you can definitely go for such restorations in compromised variole cases also, as well. So what all important things you should know? Now, one could make the argument that the restoration is actually the last step of endodontic therapy. Okay, as because you should know that no endodontics is complete without a good restoration. So please, I insist the endodontists as well that you should do or perform the post endo restorations as well. At least one endodontist should perform root canal treatment, and after that he or she should perform a good composite restoration and then send him or her back to the general practitioners for the crown or overlay or anything. So at least this is the responsibility of an endodontist, that he or she should perform a good composite restoration over that particular tooth and send it back to the referring doctor. Now, interestingly, comparisons between vital and non-vital teeth shows almost no or minor differences in the microhardness values in the time span of the 10 years after treatment. Also, we need to understand that it is important to realize that endodontically treated teeth are structurally different from non-treated vital teeth, right? Now, what is the conclusion? Conclusion at the end is that uh, mm, we should, preserve as much as of tooth structure. And you should also know that there is no substitute, no perfect substitute for lost tooth structure. So it is important that we prepare or we perform the access opening in a conservative way. But इतना भी conservative नहीं होना चाहिए कि हम access ही नहीं कर पा रहे हों, है ना? So it should be taken care of that, है ना? And everything should be possible, means the proper instrumentation and proper obturation of that particular tooth is also important. So it is important that we actually preserve the tooth structure. And as a general rule, the most tooth structure that remains, the better long-term prognosis of the restoration is. Okay. So that ends my presentation. Thank you very much to each and every for bearing me and listening me. Thank you.
Thank you so much, sir. So I would request all the participants, if you have any questions, you can mention those in the comment section. And I would request everyone that to post your questions which is relevant to the topic. So if you have any questions which is not relevant to the topic, that can be rectified in the upcoming webinars or in the previous webinars which has been uploaded in the YouTube channel. Okay, so I think so we have few questions. So I'll read out one by one.
Okay.
Okay, sir. So this one question, in case of a deep abrasion where no caries, can we go for a direct composite restoration without crown?
Yeah, definitely you can go for direct composite restorations, but you should actually inform and tell the patient about the conditions that is prevailing, that is the compromised occlusion. So it is important that you do that and consider those cases for a full mouth rehabilitation. And if he can go for that, then definitely his restored tooth is going to last longer, right?
Okay.
Yeah, but definitely you can go for composite restoration, as if he is actually not interested in going for full mouth rehabilitation, then nothing else can be done. You should go for a direct composite restoration over that.
So which was the recommended brand you had mentioned when you were talking about the premolar ring?
Premolar ring.
Yes, sir.
Okay, that is the dual force matrix. Sorry, dual force. No, that is the ring from Dentex India. That is clinician choice. I will send the link of those. Means those guys. You can order that orange ring from there.
Okay, sir.
Twin rings, I guess. This is twin ring. Twin ring के नाम से बेचते हैं उसको.
Okay. So any special instructions to be given for vertical preparation to the lab?
Yeah, to the lab you have to tell that the zirconia which is going to subgingivally, it should not be polished. It should be glazed. It should not be polished.
Okay.
And another thing is they have to decide. Means your margins are decided by the lab only. So you cannot tell much of that, but definitely you have to ask that you don't polish it, you just glaze it and send it back to you.
Okay. Okay. There's another question, sir. In
Hmm.
young patients with erupting 7 with subgingival caries in the proximal aspect, which may require deep marginal elevation, what would you advise?
In an erupting 7.
Yes, sir. Second molar.
Second molar
I
erupting
think there's.
7 means
I
what
think
erupting means? Has the active eruption taken place and passive eruption is taking right now? Taking means is going on right now.
I think it's in the. I think it is related to the young patients, sir.
So see, the eruption is of two kind, means active eruption and the passive eruption. And active eruption is something which is the by the formation of the root. Okay, and once it comes to the occlusion, then passive eruption takes place and the gingiva goes down, and that is something which is known as passive eruption. So can you means repeat me the question?
Okay, sir. In young patients with erupting 7 with subgingival caries in the proximal aspect, which may require deep marginal elevation, DME. What would you advise?
Yeah, definitely you can perform a root deep margin elevation in such cases. I think there is no problem in performing. What is the problem in performing deep margin elevation? You need to perform a deep margin elevation and restore the tooth in the way it was earlier, right? Hello?
Yes, sir.
Ranuf?
Yes, sir.
Yeah. I guess I answered the question.
Yes, sir. Okay. So I'm trying to search for the next question, sir. Okay, because some are not related to topic also. That is also there. So. Okay.
Which company vernier caliper one person has asked? It is something like, you can order in Amazon. It is not particular. I don't know. I don't remember which company vernier caliper I actually, ordered. I ordered it from Amazon. So you can go over Amazon and you can order it. No, you should not. Yeah, here someone has asked that, sir, do we need to cure or wash organosilane, or can we directly put bonding agent over it and cure only once? See, there is means you should not wash silane, okay, and you should not cure. It is not like it. You should. There is nothing called curing of silane. So just apply silane and leave it for 1 minute and let it let the let it evaporate, and after that you can apply a bonding agent over it. And you don't need to cure the bonding agent. Yes, you don't need to cure the bonding agent. Just apply a thin layer of bonding agent and then put the flowable composites and then place the restoration and then you cure it. Tack curing, and then after that final cure.
Okay.
Vertical preparation, which lab, sir? I send it to one of the labs which is in Surat, This is in the name of the lab is Advanced Dental Lab, the Advanced Dental Export. Yeah, special instructions I have told earlier for the vertical preparation. You just ask them not to polish it. Okay, just glazed zirconia. And also, yeah, it is important to understand that why we should go for zirconia. Zirconia is something which is very strong material, right? And in the thinnest part also means when we go for 0.5 to 0.7 mm of the thickness in the cervical region, it resists good amount of the the forces, the lateral and the compressive forces. Though, so this is one of the reason also that we should go for zirconia grounds only. Okay,
Okay. So there's one
monolithic
question.
zirconia.
Okay, so there's one question.
Hmm.
Do we need to use any fiber reinforced composite like Avex, or is bulk fill enough?
Sorry, actually, I haven't have any experience of fiber reinforced composites, so I cannot I cannot tell you anything about it. So once I use it, then definitely I can go. I can definitely tell you something about that. But I haven't used fiber reinforced composite till date. See, we are into the era of nano composites, right? And nano composites have got good amount of strength, compressive as well as means we are strength and everything. So I guess any nano composite today, that is good for it. Yeah, these fiber reinforced composites are something which is used just for mm, to just to uh, compensate for the polymerization shrinkage. So for that bulk fills, nowadays the bulk fill are that is available in the market. Those bulk fill comes with minimal amount of polymerization shrinkage. So I guess means I have been getting good results with injection molding technique and bulk fill restorations. So I suggest to go for such restorations only. I don't know. I don't have experience of fiber reinforced composites. Definitely in future I will use, and I will have that experience definitely.
Okay, so,
Thank you,
so
sir. Which composite you use for composite restoration? Composite which I use are multiple. I don't have any particular brand or a single brand into my clinic. I use composites from 3M, that is 350, and I use composites from uh, money. I use composites from some flowable composites from Wisdom, Intelligent Master, something that is a master design, something which is very good flowable composite, that is viscous flowable composite that you can use. And those viscous flowables, you can also restore the class 2 composites and class 1 composites, posterior class 2 and class 1 composites. They claim that. So you can have Wisdom composites as well. And I have some cheaper composites, cheaper in the sense that costs me less. So whenever I have to whenever I have to build a core, and I have to plan a crown over it, so I usually go for cheaper composites over there, those cases. So you can go for flowable composites from Prevest. Those flowable composites are good, and those composites are nano composites, nano hybrids. So I prefer going for flowable composites from Prevest as well for my core buildup. And some composites from different companies like Colteen. I have brilliant composites and all, lots of composites I do have in my clinic. So I cannot means you should have multiple brands. Yeah, any composites you can go for, whatever composite you feel like you are comfortable with, you can use those composites. And I am very comfortable with 3M composites, 3M Z350 XT. Those composites are excellent. And as they are pure nano composites, they give excellent polishability, and they have, means excellent aesthetic results at the end. So for the aesthetic in the front teeth cases, I use only and only and only 3M.
Okay, sir.
Yeah,
So,
dual force matrix. Yes, definitely dual force matrix ही जो है कहलाता है. In which case you choose light cure resin reinforced GIC with composite when you do a core build-up after RCT. Actually, I used to do light cure reinforced GIC earlier, but right now I am not into it. I don't use resin. I completely have shifted to composites. For the core build-up also, I use composites only, nothing else. Do we need to use any fiber reinforced composite like Everex or yeah, I have answered this question earlier. 7 is on active eruption and post endo restoration of 6. See, I think I am not the better person to answer this question. It is better you ask this question to any pedodontist. I guess he can answer you well. I'm really very sorry in case if I couldn't answer your question. Okay. It was gauge for metal, I think. We are if we are using paracore for post endo restorations, do we need to do composite restoration as an overlay in case we are not planning for a crown? Definitely you can go for indirect or direct composite restoration over that. You need to reduce the core that you have built, reduce it to 2 mm, and then you can go for a composite restoration or composite overlay over that, indirect or direct, whatever means you feel better. And whatever means in, if you are good in sculpting, then definitely you can go for a direct restoration over it, or else you go for an indirect. But most of the most of the lab people nowadays, they are not into composite onlays, overlays. They reject those cases, and I don't know why and the reason behind that, but they don't prepare composites nowadays. So either you need to prepare those composite overlays chair side, and then you need to place it over the patient mouth. Okay, I guess I have answered all the question.
yes, sir, you had answered most of the questions, sir. So I think there are a few more questions actually, but I
Yeah,
think
yeah.
we'll try to, yes, sir.
Thank you very much. I guess it was an informative session, right? And we
Yes,
learned
sir. Yes, sir.
something from
Def-
you.
Definitely, sir. Thank you so much for sharing your knowledge and expertise when it comes towards the post-endo restoration.
Yeah,
So definitely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. So
yeah.
thanks to all the doctors who has participated for this webinar, and I hope all of you will depart this session with positive, confident manner. So again, sir, thank you so much for your time. It was actually very informative. The presentation was actually fabulous. And thank you all the doctors who had participated for this webinar. So thank you all and have a great night.
Thank you. Good night to everyone. Bye bye. Take care.